Imagine that you are a primary care provider in rural North Carolina, the kind of town where everybody knows your name. Very small community, you're the only doctor. One day you're in your busy clinic, you get a phone call from a patient's wife. My husband can't breathe. What do you do? Now this patient, you know, long smoking history of COPD, and here he is at home and he can't breathe. What do you do? It is my goal by the end of this talk, you'll be able to answer that question. For my topic, we looked at outpatient management of COPD exacerbations. The outline, first we're going to do a background on COPD. What is this disease? Let's go back to medical school, talk about it. Second, how do we manage these exacerbations? And then we're going to go into project design, the meat and potatoes of the talk. We'll talk about the outline that I created to help manage exacerbations in the outpatient setting. And then at the end we'll go over the question and the results. Was this actually effective? Did people actually learn anything? And then hopefully future directions of the project. I had nothing to disclose. So the goals of the project. First, I wanted to develop an easy protocol for outpatient COPD management, something that is done almost on a reflexive basis for our primary care providers. Second, I want to increase primary care provider comfort with managing COPD exacerbations. Third, to reduce inpatient hospital admissions and emergency room visits for COPD. And lastly, kind of a lofty goal to reduce overall hospital costs for COPD exacerbations. So some background information. COPD, chronic obstructive pulmonary disease, extremely prevalent. 17 million people in this country have COPD. It's associated with high morbidity and mortality and high healthcare costs. It's expected to be the third leading cause of death and the fifth greatest cause of disability by 2020. COPD ranks third in mortality with an estimated 100,000 deaths annually in the US. Cost, $50 billion. In our fair state of North Carolina, about 7% of the population has COPD, and about 17% of them come to the ER at least once a year because of their COPD. 70% of people with COPD in North Carolina report that the exacerbations that they experience and shortness of breath affect their quality of life, which makes sense. So you're looking at a disease that affects 17 million people, and those people will go to the ER at least once a year because of COPD. And every ER visit actually increases their mortality. Wow, that's pretty staggering. So what is a COPD exacerbation? It's what you would expect: shortness of breath, increased work of breathing, coughing. All these very largely subjective symptoms that are basically with the patient who has COPD and they cannot breathe. So how do you manage these symptoms? Usually symptom-based care. We treat the shortness of breath with some bronchodilators. We help the inflammation with steroids, and some people actually get benefit from antibiotics. We'll talk about those people in a little bit. If your patient is hypoxic, which we'll talk about what that means, they might benefit from actually additional oxygen therapy, and those select patients may need to be hospitalized. So for the project, I wanted to first create a protocol designed using expert opinion, mainly talking to pulmonologists in my hospital, as well as using goal classification, et cetera, to create something that had a consensus of expert opinion on how to manage COPD. Then I had to distribute it. I had to go around to various clinics, family medicine, internal medicine, geriatric clinics, even skilled nursing facilities to actually go out and teach this protocol. And then third, was this effective? I had to go and evaluate the people that I just educated and see if they actually learned anything, if it was helpful, if they think they could actually incorporate it into their practice. So here's the protocol, the meat and potatoes of the talk. Basically, it's divided into three sections. You have a patient who presents with COPD, a COPD patient that has shortness of breath. And first, you have to decide, is it severe, moderate, or mild? The severe patient is the patient who is cyanotic. They have increased oxygen demand, they're confused, they're lethargic, they have respiratory distress and use accessory muscles. Those patients are stabilized with nebulizers and then immediately go to the hospital. They are hypoxic, they need to be hospitalized, no question about it. The second big group is the mild group. These are the people at home who just sort of feel out of sorts. They don't feel great, but there's no increased work of breathing, no cough. Those people you can kind of manage at home with increased use of bronchodilators, the rescue inhalers at home. They get a 5-day course of steroids, and they need to see their doctor within 72 hours. If you're not severe, you're not mild, you're moderate. So the people that have moderate shortness of breath, first thing needs to happen is they need to be treated with a nebulizer treatment. Do they feel better? Yes? Fantastic. They go down the protocol. Do they feel better? Do they not feel better? No. They get a second nebulizer treatment. At our hospital, we use duo nebs. If they don't feel better after 2 nebulizer treatments, these patients need to be treated as if they are severe. They go ahead and go to the ER for further evaluation. If after 2 treatments they feel better, then you can go down the protocol. Are they coughing up anything? Yes or no. If they're not coughing up anything, you can treat them like a mild exacerbation, i.e., increase your home rescue bronchodilators, a burst of steroids, and need to see the doctor within 72 hours. If they are coughing up anything purulent, then they need antibiotics. What antibiotics would you choose? It's based off their history. Have they been hospitalized for the past 3 months? Have they been in the ER multiple times? Do they have a history of being colonized with Pseudomonas? Yes or no? If they don't, they're an uncomplicated COPD patient. They can be treated with Bactrim or doxycycline. Those who do have a history of Pseudomonas or are at high risk for Pseudomonas need a higher antibiotic, such as Levaquin. Regardless, they need to be evaluated within 24 to 48 hours. After this protocol was distributed and taught, I had to see if the providers actually learned from it, if it was actually effective. So I gave out a quick little survey, and the results are as follows. So the first question was, how would you describe your comfort in managing COPD prior to the actual protocol? As you can see, most people, they were comfortable with whatever they were doing. I'm not sure what they were doing, but they were comfortable with it. A few people were kind of in the middle. And then prior to education, what did they actually do? And most people had people come into the clinic for an acute care visit. Some actually wanted to see the patient within about a week or so. Now, after the education session, I was happy to see that a lot of people were very comfortable with managing COPD exacerbations, even in the quick 2 minutes that I spoke to them about it, and then a few were somewhat comfortable. Prior to the education session, the most limiting factor as to what frightened providers the most was whether or not was their concern for hypoxia. And as I mentioned, people who are hypoxic, they go to the ER, they're treated there, no questions asked. After the education session, what was the primary method for managing COPD, and now it's invoking an action plan or having patients come in for an acute care visit, which is important because we know that these patients need to be evaluated sooner rather than later. So future directions of this project, I've spoken to about 4 or 5 clinics. I would love to speak to more of the nursing homes, especially that refer to patients to our hospital very frequently. I would love to determine if after I reach out to the majority of people, or our team does, if this can actually have an effect on our hospital admissions. And overall, the goal of everything to reduce hospital costs. These are my references, and I'm open for any questions. Thank you very much.